All right, team, gather round. Welcome to this explainer. I'm going to be your senior resident today, and we're stepping right up to the bedside to dive into the clinical reasoning behind diagnosing heart muscle diseases. As focused learners, I know you want the direct, high-yield clinical logic, so we're going to build a rock-solid diagnostic framework together.
So here's our game plan for rounds today. We'll break down our live bedside case, map out the 3 distinct shapes of heart failure, tackle the dilated cardiomyopathy diagnostic workup, compare hypertrophic patterns, distinguish a restrictive muscle from a constrictive mimic, and finally, build a solid long-term management plan. Okay, let's get into it.
Section 1. The bedside case presentation. Meet Mr. Okafor.
So we're seeing Mr. Okafor. He's a 54-year-old guy coming in with 3 months of progressive breathlessness and some pretty bad ankle swelling. Lately, he gets winded just walking up a single flight of stairs. He literally tells us, "I woke up at night gasping for air, I can't catch my breath." He's sleeping on 3 pillows now. This brilliantly illustrates the pathophysiology of backward failure. His heart simply cannot move blood forward effectively. So what happens? The volume backs up. Increased hydrostatic pressure forces fluid right into his lungs, causing that orthopnea when he lies down and that terrifying paroxysmal nocturnal dyspnea that wakes him up gasping.
Now, looking at his physical exam, we clearly see the elevated jugular venous pressure and hear those bibasilar crackles. That firmly confirms the backward congestion. But check this out. Pay close attention to his PMI, the point of maximal impulse, is displaced downward and outward. Plus, you can hear this soft, low-pitched S3 gallop. Boom. That specific combination, it points us directly to a dilated, stretched out, and failing ventricle.
Okay, so what's our first diagnostic rule out here? Well, by definition, a cardiomyopathy is a primary disease of the heart muscle itself. To make this diagnosis, we literally have to prove the muscle is the main culprit. We have to methodically rule out the secondary mimics. Like, is there a blocked coronary artery? Is there a blown primary valve? Is it just a stiff pericardial sac? Once we clear all those secondary mimics, then we can focus entirely on the muscle.
Section 2. The 3 heart shapes, the organizing framework.
You know, to keep our heads straight during hectic clinical rounds, it really helps to categorize these primary muscle diseases into 3 distinct shapes. If you get the shape, you get the pathophysiology. Let's use some simple analogies. First, the dilated shape. Thin walls, huge cavity, severe squeeze problem. It basically acts like an overstretched, baggy balloon. Second, the hypertrophic shape. Incredibly thick walls with a tiny cavity. Think of it as a muscle bouncer blocking blood from getting out. And finally, the restrictive shape. Stiff walls with massively enlarged atria trying to push blood in, acting like a rigid concrete box that simply refuses to fill.
Section 3. Dilated cardiomyopathy diagnostic workup.
All right, back to Mr. Okafor. Because of that displaced apex and the S3 gallop, we're putting him right into the dilated category. But we can't just guess, right? We've got to prove it. So we use a rapid, step-by-step diagnostic sequence. Step 1 is the bedside exam and the ECG to look for clues like rhythm issues. Step 2 is the echo. That's our gold standard to actually see the shape and measure the squeeze. And Step 3 involves targeted labs and an advanced cardiac MRI to hunt down the specific underlying etiology or scarring pattern.
And sure enough, Mr. Okafor's echo comes back, revealing an ejection fraction of just 25%. Normal is typically above 50%, so this completely confirms the pathophysiology of severe systolic dysfunction. The walls have thinned out, the chamber has ballooned, and the muscle just literally cannot squeeze hard enough to eject the blood.
Okay, let's do a little rapid-fire board review. Question for the med students on the team. Let's say an angiogram proves this patient did not have a heart attack, meaning 0 ischemia. What primary factors can actually dilate a heart to this extent?
Well, the answer involves hunting down things like toxins, genetics, infections, pregnancy, and stress. Just a quick mental checklist to run through at the bedside. For Mr. Okafor, diving into his social history reveals he drinks about 6 to 8 beers a day and has for years. That makes alcohol toxicity our absolute prime suspect for his dilated cardiomyopathy. Though, honestly, we can't completely ignore a genetic link since his brother apparently had an enlarged heart too.
Section 4. Hypertrophic patterns and murmurs. Let's shift gears for a second and see how this builds our differential by moving to the second shape. We're going from the floppy, dilated balloon to a massively overgrown muscle, hypertrophic cardiomyopathy, or HCM. You've probably heard of this. It's a notorious leading cause of sudden cardiac death in young, seemingly healthy athletes. To diagnose this shape, the strict echo criteria require a left ventricular wall thickness of 15 millimeters or greater. And crucially, this thickness has to be out of proportion to any normal workload, like chronic hypertension. It's caused by these sarcomere gene mutations that create a super disorganized muscle fiber architecture, which acts as a really dangerous substrate for arrhythmias.
Now, here is a super high-yield board review pearl you are absolutely going to see on exams and out on the floor. That thick septum in HCM physically blocks the outflow tract. So if the patient does a Valsalva maneuver or stands up, what happens? It decreases venous return, emptying the ventricle. And a less full ventricle means those thickened walls are closer together, which dramatically worsens the obstruction. Because of that, the HCM murmur actually gets louder with standing or Valsalva. That's the exact opposite of aortic stenosis, which gets softer because there's just less volume flowing across the valve.
Section 5. Restrictive muscle versus constrictive mimic. All right, moving to the third shape in our framework, the concrete box. This is where we run into a really tricky bedside diagnostic dilemma. The ventricle isn't vastly dilated, and it isn't massively hypertrophied. The muscle is just way too stiff to relax and fill during diastole, causing massive pressure to build up in the atria behind it. We have to carefully use our physical exam and imaging logic to separate a true restrictive heart muscle from constrictive pericarditis. Constrictive pericarditis is just a stiff sac surrounding a completely normal heart, but it perfectly mimics the exact same physical signs of right-sided heart failure, like the elevated JVP and edema. We have to tell them apart, usually with an MRI or specialized echo, because a restrictive muscle is treated medically, while constrictive pericarditis is treated surgically by literally stripping away the sac.
Time for another rapid-fire board question, guys. What is the diagnosis when you are looking at an echo showing profoundly thick ventricular walls, but then you glance at the patient's ECG and see incredibly low electrical voltage?
Boom, it's the amyloid paradox. This is such a cool, absolutely crucial bedside clue. Normal muscle conducts electricity, right? So thick muscle usually means high voltage. But in amyloidosis, rogue infiltrative proteins pack into the heart walls. And because these proteins do not conduct electricity, you get this massive mismatch. The echo shows thick walls full of protein, but the ECG shows low voltage because there is very little actual healthy muscle left.
Section 6. Long-term medical management plan.
Okay, let's bring all this clinical reasoning right back to Mr. Okafor to map out his transition from acute, gasping failure to a solid, long-term plan. Now that we've correctly categorized his shape and etiology, how do we actually treat him? First, we initiate guideline-directed medical therapy, or GDMT, to support that failing dilated ventricle. Second, we have to mandate complete alcohol abstinence. Getting rid of the toxin gives the heart a genuine chance to reverse the disease. And third, we've got to screen his first-degree relatives, given his brother's history of an enlarged heart.
I want to leave you all with this final thought. We always have to aggressively search for reversible causes like alcohol or tachycardia. But, and this is critical, if Mr. Okafor's ejection fraction is still sitting at 25% after months of maximum medical therapy, his risk for a fatal arrhythmia skyrockets. If this muscle doesn't heal, he's going to need an implantable cardioverter defibrillator to monitor his rhythm and shock him back to life to survive. So the next time you're at the bedside, ask yourself, are you just treating the symptoms or have you actually found the shape of the disease? Thanks for rounding with me on this explainer team. Catch you next time.